Diabetes is, of course, a systemic disease, and we often talk about the effects of diabetes on organs such as the kidney, and even now the brain. But an organ that seems to have been forgotten is the lung. Well, I hope my next guest is going to put an end to that by telling us a bit about the lung, the forgotten organ. So, Stefan Kopf, welcome.
Thank you.
Why is the lung a forgotten organ in diabetes?
That's a really good question. Why is the lung a forgotten organ? For this, I have no answer, because when you look in the literature, there are previous studies that already describe that diabetes patients have reduced lung function. And there were also studies in the early 90s, post-mortem studies, that pathologists saw that the lung has a fibrotic phenotype in diabetic patients. But the diabetologists, we forgot it completely. And when we talk with pulmonology physicians, they tell us, yeah, you forgot it, because we see these effects. We see that diabetes patients has reduced lung function, they have breathing problems, they have a higher progression in lung diseases like pulmonary fibrosis, but also COPD, and it's very interesting.
Why is there this effect on the lung? What is the mechanism?
The mechanism is not completely understood at the moment. The lung is the organ in our body which is exposed to a high concentrate of oxygen, 21% oxygen with every breath we take. So, and you have a high rate of reactive oxygen species in the lung, and the lung has to deal with this. And in diabetes, as a systemic disease, you have a metabolic disturbance. You have high glucose in the cells, you have detoxification problems of reactive metabolites, you have DNA damage, impaired DNA repair. And together with this high exposure of oxygen, we think the pathomechanism is a combination of DNA damage and disturbance of metabolites, which lead to an inflammatory phenotype in the lung. And when an inflammatory phenotype exists, then the immune system will go into it to solve the problem. And when it's not possible to solve the problem, the tissue get fibrotic. And you can see it in the kidney. When you look at histology examinations of the kidney, you have a fibrotic kidney disease in diabetes. When you look in the eye, in the end stage retinopathy, there is a fibrotic tissue. And in the liver and in the nerve also. So
we should expect to see it in the lung too?
Yes. And when we look in patients with pulmonary fibrosis, diabetes patients are highly overrepresented in this patient cohort, and diabetes is a very high and very severe comorbidity for these patients.
So what does this mean for the average clinician? What should they, because you're suggesting that there is a diabetic pneumopathy. Do you know, this is the worst word to say. It's a terrible word in English to say, pneumopathy.
Pneumopathy, yeah. From the data we have now at the moment, we suggest that we should screen patients more for lung impairments. So the first step would to be ask the patient about dyspnea or breathlessness. Yeah? And after the patient report about breathlessness, then we should think in two ways. First, cardiac disease, of course. We know it's also overrepresented in diabetes patients, but in less than 11% of the patients, the breathlessness is caused by cardiac disease. Then we go further and make a lung function test or a 6-minute walking test. It's very easy to do this. And when we have impairments in lung function tests, then we should send him to a specialized center. Like Heidelberg, we have a good collaboration with our pneumology department in the thorax clinic in Heidelberg, and together we also made the study.
Very good. So there you are. You should not ignore the lung. It's part of the system affected by diabetes. And that message comes loud and strong from what you've been saying. Thank you so much.
Thank you.
And you can see that presentation, which is on diabetic pneumopathy. Can't say that. The lung, a forgotten organ. Let's say it like that instead. You can see that on EASD.org.